My name is Lisa Cooper. I'm a professor of medicine and also a Bloomberg Distinguished Professor at the School of Public Health here at Johns Hopkins. And, I also direct the Johns Hopkins Center for Health Equity, where my colleagues and I partner with the community on clinical trials targeting providers, patients, as well as healthcare organizations' ability to better address the social determinants of health in their populations. And it's my pleasure to be your moderator for this panel on race and health today. I'm going to introduce our other panelists, and then we'll talk a little bit about how we would like to organize the panel. So first, I'd like to introduce Dr. Leana Wen. She is the Commissioner of Health here in Baltimore. She runs America's oldest public health department, founded in 1793. Dr. Wen is a practicing emergency medicine physician and a passionate patient and community advocate. We also have Dr. Robert Hahn. He's an epidemiologist with the Centers for Disease Control and Prevention, where he served since 1986. He is currently the coordinating scientist of systematic reviews of interventions to promote health equity with the Guide to Community Preventive Services. And in Berkeley, we have Dr. Mahasin Mujahid. She is professor of public health and epidemiology at UC Berkeley School of Public Health. Her current research examines how features of neighborhood environments impact cardiovascular health and health disparities. So welcome to our panelists. So this panel is unique at this conference. Unlike the other panels that were presented on housing and on education and on policing and employment, health actually did not have its own chapter or standalone set of recommendations in the Kerner Commission report. We want to explore why that was the case and if a modern day Kerner report would actually have its own section and its own set of recommendations on health. But despite not having its own section on health, the report did cover certain issues related to health. Specifically, it called out infant mortality as a contributor to disparities between white and non-white populations. It also called out life expectancy, access to care, and the role of neighborhood, or ghetto is the term that was used in the Kerner report, environments and poverty in health. So we want to explore with this panel what these disparities looked like back then and what they look like today. And then finally, we know that the field of public health has really grown over the past 50 years. It has advanced a lot of our knowledge about health disparities and health equity. And we know a lot more now than we did 50 years ago about issues related to trauma and violence, to mental health, and to other social determinants of health, as well as the impact of preventive services and primary care on health equity. So we want to discuss what a modern day Kerner report might look like and what those recommendations might look like, as well as policy issues that it might address. So the first thing that we're going to talk about today is back then and now. And so what I'd like to do is to start out with Dr. Wen. So Leana, you were appointed to the Baltimore City Health Department as commissioner in January of 2015, and that was just a couple of months before the unrest began here. So there are some parallels between the unrest that took place in Baltimore and the unrest that took place in several other US cities and the reasons for those issues. Could you discuss the significance of recognizing the 50th anniversary of the Kerner Commission report here in this city from a public health perspective? And then also, can you tell us how the Baltimore City Health Department responded to the unrest in Baltimore in 2015?
Sure, thank you, Dr. Cooper, and hello to everyone. It's nice to see so many familiar faces here in Baltimore and imagining in Berkeley as well. You know, if we just take a look at where we are right now, where we're sitting, in Baltimore. And, I was going to show some slides, but actually I decided not to, because no matter what you look at in our city in terms of health statistics, I can basically replace the legend with anything, and it'll be the same. As in, I can show maps of Baltimore of life expectancy, and you'll see that there are neighborhoods just a few miles apart where a child born today can expect to live 20 years less or more than a child born in a neighborhood just a few miles away. And that life expectancy map also correlates to infant mortality. It also correlates to cardiovascular death. It also correlates to drugs. It also correlates to deaths from violence. By the way, it also correlates to poverty, because it's been said that the currency of inequality is years of life, in which case the corollary is that the opposite of poverty becomes health. Now, we are also in the shadow of amazing medical institutions, right? People come from all over the world to access healthcare at Johns Hopkins, University of Maryland, and so many other places. And so we know that it's not just about health care that determines how long or how well we live. It's all these other social determinants. And I think it's impossible for us to then talk about health without also discussing these social determinants and the history of how we got to where we are. And so I think that addresses why it's so important that we're having this discussion here in Baltimore, that we have to acknowledge and be honest about the history of where we came from, redlining, the war on drugs, the failed war on drugs, and how that got us to where we are too. I want to answer Dr. Cooper's second part of the question. I think we'll get to some of these first themes about what we did in the wake of the unrest back in April of 2015. People, I'm sure there are images that come to people's minds about Baltimore and the unrest. If you Google that, you'll see cars burning, stores burning, youth doing things. And that's not what I saw. Because in the immediate aftermath of the unrest here, what I saw and what I heard were of people trying to access basic life-saving services who couldn't. At least 13 of our pharmacies were burned down or looted or closed. And for me, as a physician with a car, who's able-bodied, I can drive to another pharmacy, call in my prescription if I need one, and it's not an issue. But for someone, we had calls from people who couldn't get their insulin. I remember this one patient who said that by the time that she called, she couldn't see and was nearly unconscious. I mean, she could barely speak. And she said that she was out of her insulin and thought that the best way to keep herself from dying was to stop eating as well. Or somebody else was so short of breath that by the time he called, he could barely speak in 2-word sentences. And I asked, what are you out of, what medication? And it wasn't his inhaler for his asthma. It was actually a blood clotting medication, because he was being treated for blood clots in his lungs, and he was literally dying because of blood clots that were there. And so our immediate reaction was to get medications into the hands of people who need it by setting up a 24/7 medication and food access line, because many people also depended on pharmacies and corner stores for food. And then in the aftermath, also then focused on treating the longer term issues, trauma, mental health, addiction, and then focusing on, now that there's attention finally to these longstanding injustices, what can we do to reverse things so that we are understanding how these social determinants contribute to health and lack thereof, and how can we make an impact and lasting impact as a community.
Thank you, Leana. I think you are one of the examples of a courageous advocate and someone who took advantage of the right moment in time to actually bring to bear the expertise and the strength of public health and its ability to partner with communities to address a lot of these issues. Thank you. I'd like to turn to Mahasin, Mujahid. And Mahasin, we'd like to talk a little bit more about some of the specific social determinants of health that Leana mentioned and that the report actually described in some detail. So they referenced environmental conditions in African American neighborhoods as a reason for poor health conditions. And they specifically called out a lack of ability to store food safely, for example, by having refrigerators or freezers. And they also pointed out issues related to poor sanitation and rats and infrequent garbage collection in those neighborhoods. Could you speak to some of these conditions and their impact on health, and what types of neighborhood impacts are driving health disparities now?
Sure, thank you, Lisa. So I first want to begin by stating that there was actually a lot of interesting work that was going on sort of in the late 1960s and early 1970s, around the same time as the Kerner Commission report, that was highlighting how features of neighborhood environments were in fact impacting health. So one example of that is there was some work out of the University of Michigan by Dr. Ernie Harburg, where he was looking in Detroit, actually, in Highland Park, Hamtramck, and Detroit, to show how blood pressure was related to the conditions of living in urban environments. And interestingly, in that work, he showed that some of the differences that we see between blacks and whites in terms of blood pressure was a function of differences in the living conditions and in exposure to these urban stressful conditions. And then there was similar work that was going on as well in North Carolina with Dr. Sherman James doing work showing similar patterns there. And then right here in the Alameda County area, there was work being conducted by Dr. Mary Hahn and George Kaplan in the Alameda County study that began in 1965. And in this work, they show that individuals that were living in high poverty areas had higher mortality compared to those who were not. And so at that time, although it laid a really wonderful foundation, there were a lot of limitations and criticisms of this work. So one of the criticisms was that it wasn't anything about sort of urban environments or neighborhood contexts that mattered. It was instead a function of poor people behaving badly. And these people happened to cluster in certain areas. And so therefore, it was a sort of argument around blaming the individual. So they were making bad decisions, poor choices, that was impacting their health. And then it just happened to correlate because people clustered in certain areas. And the danger in this argument is that it removes any accountability to do anything about the actual conditions people were being exposed to. So that was one key limitation of the work. And then the second key limitation is there was very little empirical work that was documenting what was it about these environments. So we know poverty is bad, but that hasn't been motivation in the past for us to do something about it. So what is it about poor neighborhood environments? Was it about access to resources? Was it about exposure to crime? What were those specific features of environments? So now if we fast forward, we've done a lot of work to really understand the role of neighborhood environments in shaping health across a variety of outcomes. I've done a lot of work in the area of cardiovascular disease, but there's examples across any kind of outcome you can think about, from infant mortality to overall mortality in the young, in the old, morbidity, mortality, sort of a wide range of outcomes. And now what we understand is that features of these environments actually matter. So having limited access to healthy foods is associated with poor diet quality, higher levels of obesity, and also with higher levels of coronary events over the life course. We also know that exposures to poor social conditions around high crime, dilapidated buildings are also associated with these same outcomes. And we also know that environmental exposure, so being exposed to air pollution and other environmental toxins, are also increasing risk for cardiovascular outcomes as well. And then the other thing that we know is we really now understand the mechanisms that are linking these poor environments to poor health outcomes. And so one of the environments is actually through health behaviors, but it's not because poor people behave badly, but instead they have constrained choices and options. And so therefore, having constrained choices creates a profile or sort of social norms around certain behaviors that are more a function of the environment than a function of those individual choices. We also know that it is directly affecting biology through stress-related processes as one example. So we know that constant exposure to these heightened stressful environments causes wear and tear of the body, and that also causes accelerated aging, and that this accelerated aging breaks down not only the cardiovascular system, but other systems in the body. And then now there's also exciting work to actually show that it's changing biology and genetics. And so exposure to stressful conditions can actually regulate genes off and on through epigenetic processes. And so we have a wealth of information now to really understand that environments can in fact make us sick. And so therefore there's a call to action to do something about improving these environments. And the evidence is so good that major organizations such as the American Heart Association that I work closely with is taking on this initiative of health equity, is taking on this issue of addressing the root causes of health, and these include social determinants.
Thank you, Mahasin. That was a wonderful review of how much we've learned about this and how we're now connecting the importance of environmental circumstances to health behaviors and its contribution to health inequities. I'd like to turn to Robert now and ask you, Robert. You've been studying trends in mortality and life expectancy across race and sex. And how have these trends changed over the last 50 years?
A few notes before I give you the statistics. First of all, I'm not speaking on behalf of CDC. I've worked there for a long time, but I'm not representing them. I'm also personally motivated to make sure that, along with many of you who are here at this meeting, that the next time we celebrate the Kerner Commission report, we're celebrating its fulfillment rather than its very partial fulfillment. I lead a team that works on what we call health equity, and we define health equity not only as having equivalent health, but as having equivalent backgrounds in terms of major social determinants. And I see health more and more as sort of the canary in the minds of society, so that when a canary falls over, we have a sign that something is wrong in society. And I see the trends in mortality and life expectancy and infant mortality as indicators of social problems that have not been addressed. And so, before I get to my conclusion is that the remaining disparities in health status, inequities we see in health status, are a consequence of remaining institutional racism that we have failed to get rid of. The social determinants that I've worked on are education. I recently published a paper on civil rights and public health. This afternoon, you're going to hear a presentation by Professor Rucker Johnson of Berkeley, who's done an incredible study of the effects of school desegregation on the long-term well-being of Black students who then have the opportunity to attend desegregated schools. Essentially, the gap in achievement for Black and white students disappears. These students have improved economic benefits. They commit fewer crimes. And this is a remarkable study. And but you can see the same thing with civil rights. The Civil Rights Act of '68 had immediate consequences in terms of infant mortality in the South. The only arena in which the Civil Rights Act and its sequelae have had limited effects are in housing, as we've heard about yesterday. Segregation remains a major root of much health inequity. I and a few colleagues have actually it's coming out next Thursday, done a study of mortality among women in the United States from 1900 to 2010, looking at mortality by cause at every decade. This graphic shows mortality trends by race and gender from 1900 to 2010. These are age-adjusted rates. Unfortunately, information on specific to Blacks became available only in 1970, so we separated that out in only in 1970 and forward. But you can see declining rates of all-cause adjusted mortality from 1900 to 2010, and the rates for non-whites were actually accelerated at a more rapid rate than the rates for whites, for both males and females. Beginning in 1970, the rates for Blacks were higher than those for other non-whites, but they have continued to decline over that 40-year period. I took the ratio of non-white to white mortality and Black to white mortality for males and females over this period where the data were available. And you can see again that the ratio has declined more or less in a bumpy trajectory over this period. But beginning in 1970, you can see that the ratio is higher for Blacks than for other non-whites, and it peaks in 1990. If you ask me Why that is, I won't be able to tell you, just to warn you. But after 1990, the ratio has declined for both males and females, and it's continued to decline beyond the point on this graphic. And this is my last graphic. So this plots a ratio, the difference between white, non-white, and white life expectancy, again, since 1900. It's kind of a peculiar graphic in that the first 80 years are squished into the first small area of the graphic because the data are not available for intervening years. But you can see that there's been, again, a substantial decline in the difference between white and black mortality for life expectancy for males and females over this period. A rise in the 80s, and then a slow decline after that period. But again, even in 2015, black males lived 4.4 years less than white males, and white females lived 2.8 years longer than black females. And again, this, I believe, is the result of ongoing institutional racism, and these gaps will not disappear until the social determinants that produce them have also disappeared. The gaps between social determinants, education, housing, segregation, and so on have also disappeared.
Thank you, Robert. I know that we've seen patterns similar to this, and even in Baltimore, for example, where life expectancy at birth continues to demonstrate a 3 to 4 year gap between African Americans and whites, and as Leana mentioned, even greater depending on which neighborhoods we're comparing to one another. And we've also seen that probably the largest contributors to that difference in life expectancy are related to factors such as infant mortality, trauma and violence, deaths from overdoses, that kind of thing, and then also cardiovascular disease, of course, a major contributor. But we have had some success with our infant mortality rates, and I think that's we'd like to share more success stories as we move forward. Right now, what I'd like us to do is to talk about why the Kerner report didn't have a chapter on health, and whether if there were a current present day report, what we would actually see in that report. So, Robert, going back to you just for a moment, 50 years ago, social determinants of health as a term was not really part of our lexicon, as much as it is today. So could you talk a little bit more about social determinants and what would have impacted the Kerner Commission report if more was known about those social determinants at that time?
Well, they didn't have the language to talk about social determinants, but they certainly talked about social determinants. As we've seen, they talked about employment, housing, transportation, the justice system. So I don't see that as a major omission. When I came to CDC in 1986, not only was half of the cafeteria space available for cigarette smoking, but the newest thing on the block was behavioral risk factors. And we had launched surveillance around the country of how people behave, smoking behavior, eating behavior, physical activity, and so on. And that was the new thing. And social determinants became more and more prominent maybe 15 years later, and is now a vibrant part of what we do, as well as health equity. In public health overall, actually, there were movements towards notions of social determinants in the 19th century. There was a famous pathologist, Rudolf Virchow, in Germany, who not only was a pathologist, but also had developed notions of social medicine and saw the state as largely determining people's welfare. And there also was Friedrich Engels and Emil Durkheim, a sociologist at the beginning of the 20th century. There's also a new notion which has been introduced by anthropologists, which is called syndemics, which is a notion of the confluence of multiple determinants of health in adverse directions, which was mentioned yesterday, but with a different terminology. I still don't think that social determinants are well understood in public health. Their basic causal nature is somehow given a lesser status than that of the TB bacillus or cigarette smoking in pathology. That's not my view, but that's, I think, the way public health people think. So I think we still have a long way to go. And another issue is that in public health, even though we recognize social determinants as important, we are reluctant to act in those domains. Education is somebody else's business. Housing is somebody else's business. So we're very cautious about treading on other people's turf.
Right. I understand, but I appreciate that, based on what Mahasin spoke about, is that there has been a lot more research and empirical data that demonstrates the important role of these factors. So, and another thing that I appreciated is that the Robert Wood Johnson Foundation a few years ago published some work helping actually public health professionals and health professionals understand how they could better describe social determinants of health when talking with folks that aren't in the field, and gave us some good tips about how that language allows people who have different perspectives on politically, perhaps, or views on personal responsibility and health and that sort of thing, to better understand where people live, work, play, and go to school, how that actually impacts upon their choices and their ability to be healthy. So I'm very very optimistic about the fact that more people are starting to understand how social determinants affect health. Mm-hmm. So I'm going to turn to Leana for a moment, and because we now know so much more about this, I'm wondering whether you can tell us a little bit more about how you work to make sure health stays at the forefront of the agenda of policymakers when you're talking with them.
It's really hard. I look at the Kerner report, and health is not explicitly mentioned, and I'm not surprised because it's not mentioned now really in anything. I mean, when you see what it is that elected officials or people want to be elected officials run on, they want to run on jobs, they want to run on safety, they want to run on education. I think all of us in this room and in Berkeley too, I think we all understand how those issues directly tie to health. And we need to make that explicit and say, how are children supposed to learn if they have abdominal pain from not eating, right? Or how are we supposed to have a workforce if there is untreated mental illness and drug addiction? Or how can we talk about public safety without also addressing poverty and homelessness and other issues that tie to this? I think we can make that argument. The difficulty is that it's been said that there is no face of public health. I mean, public health is there's no face of something that didn't happen, right? We're all about preventing something from happening. And I think Mayor Landrieu touched upon this as well. I mean, there's a failure when you see public health almost, that, there's a restaurant that caused people to be poisoned. That's a failure. But what about all those inspections that took place to prevent the poisonings from happening? Or somebody got shot. I mean, I'm an emergency physician. I know what it looks like when somebody got shot, but what about all the work that was done to mediate conflicts before that occurred, or to keep our children in school so that they don't become perpetrators or victims, or that the work that we did to prevent lead poisoning that then also improved educational outcomes? So I think there are two things. We have to keep on making the case for policymakers, because if we don't put that face on public health, nobody's going to. We have to refuse to be invisible, even if public health sometimes demands us to be invisible. We have to make it known. But I want to give a second idea too, which is that we have to talk about the successes that there are. And Dr. Cooper alluded to this before, that, I think there's a lot of rhetoric around choice, but we have to understand that choice is based on privilege, and that public health can be a tool that we have to level the playing field. So an example, I'll give you two examples from Baltimore City. We have a program here called Be More for Healthy Babies, which involves home visiting for pregnant women, access to services including free cribs, housing services. As a result of this program that involves a public-private collaboration with over 150 partners, we've reduced infant mortality in our city by nearly 40% in just 7 years, and closed the gap between Black and white infant mortality by over 50% in that same time period. Now, we need to tell more of these stories because I think there is a pervasive narrative about Baltimore, about other inner cities, about how you can just dump all the money you want and nothing's going to happen. But actually, something's happened. And we really moved the needle on something as fundamental as infant mortality. Who argues that that's a bad thing? Another example that I'll give is we also started a project together with our partners, including City Schools and Johns Hopkins, called Vision for Baltimore. And, I'm all about research and science, but I don't need another study to tell me that if kids can't see, they can't read. By the way, we also had excellent funding for our program from folks who are here, including the Able Foundation and Casey and others. There was a study actually done by Able and others that found that less than 20% of children who needed glasses were getting them, which is up to about 10,000 kids every year. I mean, crazy, right? How many more studies do we need to show that that's something that's so fundamental? And so this program, that's another public-private partnership, is going to, within 3 years, do vision exams for every child in every grade, K through 8. And we're going to get glasses to every child, regardless of ability to pay, and without the child or the parent missing school, because it's delivered through a mobile program. Something like that really helps to level the playing field. And I think it's an example of how one small intervention in public health makes a big difference for other things. And then it ties us back full circle about how social determinants make a difference in health, and also how health impacts everything else that may be at the forefront of other people's minds.
Thank you, Leana. That was a very nice segue to the next topic that I wanted us to address, actually, which is current day solutions to many of these health equity issues and examples of, promising practices that include collaborative partnerships across sectors, specific issues that funders, for example, could do, what people in different sectors could do to actually contribute to solutions. So I'm going to turn to Mahasin. And ask you, Mahasin, the CDC and the National Academies of Sciences, as well as many schools of public health and universities, are now working on based on several recommendations that have come out about how to better address these environmental and social determinants of health to address health inequity. So many of them are actually focused in on communities and how communities can work. So it's not sort of waiting for a policymaker maybe to decide what's going to be priority, but actually using the strengths of communities to move the needle on many of these issues. So could you tell us a little bit more about what some of this work has shown and what more promising strategies are? I know Leana has told us about a few in Baltimore, but I know that the reports from the National Academy of Medicine included several from other areas of the country and other neighborhoods and communities.
Yes, thanks, Lisa. So there was a recent report that was commissioned by the Robert Wood Johnson Foundation, where they reached out to the National Academy of Sciences, Engineering, and Medicine, and they really wanted to find examples of community approaches to address health equity. And one of the things that this report was very explicit about was the premise around health equity and defining it. And so I just think it's important for us we throw this term out a lot, but their definition of health equity is that everyone has the opportunity to attain his or her full health potential, and that no one is disadvantaged from achieving this potential because of socially defined circumstances. And so the commission was really to identify examples across the country. They ended up identifying 9 examples across the country and really looking at what were the hallmark features of these examples and what can we learn from them and what more needs to happen to really understand how we can work with communities to improve health and to address health equity. And so a couple of recommendations that came out of that report, and also from other efforts across the country from other organizations, from the National Institutes of Health, other federal agencies. This is something that everyone is working tirelessly to really understand, is what are the must-haves? Like, what do we need to really build these community-based approaches? And so a couple of things on the list that have been generated are, first and foremost, we need multisectoral approaches and partnerships. That it's really important for us to understand that health is more than just medicine in the healthcare field, and that we need to partner with other agencies and organizations, from local governments to school districts to education, transportation, housing, et cetera, to really understand sort of health in all policies. And then the other recommendation is that communities need to be central and at the forefront of these efforts. And so there's a lot of work that's been done to define community-based participatory research efforts, which is more than just conducting a couple of town halls in communities, but really including communities at every stage of the work, and to consider them as their own local experts in terms of not only sort of the negative events that are happening in communities, but also the positive assets and resources that can be used, we can leverage to work towards fixing problems. The other thing that the National Academy of Sciences report really emphasized is that, and this is a similar thing, is that we have to tell the truth, and we have to have funding agencies committed to funding work that is identifying how structural racism is operating and how implicit and explicit bias is operating. And until we can have honest and real conversations that are supported by resources and empirical evidence, we really are going to have a missed opportunity to really improve the problems that we're facing. The other thing is that there really needs to be a rigorous evaluation of these efforts. Things are happening all of the time, and as was mentioned, there are a lot of things that are happening that impact health that are other social policies that are not necessarily health policies. And so there are things happening in urban renewal approaches across the country. There are things happening in housing. There are things happening in transportation. And the idea is that when we create these multisectoral partnerships, we can think about how the decisions that are being made in relation to these other sectors, decisions that are being made in relation to housing, and decisions that are being made in relation to education also impact health. And so that's where the sort of health in all policies idea comes from. And in terms of these evaluations, I think one of the things that we're really realizing is that when we empirically study these problems, we want to identify independent effects. We want to isolate that the food environment is the most important environment, independent of everything else that could be going on in communities to impact diet or obesity. And the reality is that these things are happening in combination with other exposures. And so we're not going to see the kind of changes that we need if we only focus on the food environment or we only focus on crime. We really need to have a multi-pronged approach as well as a multi-level approach to really address the circumstances that we are trying to address. And then the final thing that I'll say is that we really need to understand that while the kind of long-term health outcomes are important, that these are things that are chronic in nature and that are happening over a long period of time. And so we can't expect our evaluations to document positive outcomes in a short period of time. It's going to take time. And so we really need to focus on intermediary outcomes that are addressing root causes, and that this is still evidence in support of the potential health improvements of these efforts that we're making. And so I think I'll stop there and turn it back over to you.
Thank you, Mahasin. That was great. And I just want to add that from a personal perspective that I've actually learned this firsthand, being a physician, actually getting outside of the clinic, outside of the hospital, and getting connected to the people and the organizations within my community. The community that I serve has completely changed my perspective on how to address the problems that I was seeing from patients in the clinic. And I couldn't agree with you more. Our community partnership has actually just been critical to our ability to just have greater impact beyond what we were doing by just focusing one patient at a time, or even on groups of patients who came in to see us. We were able to actually impact upon people who maybe we never would see in the hospital or in the clinic, but who, by learning more about what some of the struggles were in those neighborhoods and learning where the resources were and who we could work with to address those things, we could have much greater impact. So thank you. We have about half an hour left, so we're going to have a few more comments from the panel, and then we're going to open up for discussion. So I wanted to make sure, Robert, you got a chance to comment on any other best practices in this area based on the work that you've been doing with the Community Guide branch at the CDC.
Thank you. I work for a project called, somewhat immodestly, The Guide to Community Preventive Services. The idea is to systematically review public health interventions to try and figure out assess the state of research, assess the state of knowledge, to figure out what works, what doesn't work, what may be harmful, and what needs more research. Actually, one of the first reviews I did in 2000 was on early childhood home visitation programs for low-income, mostly single mothers, and which has many benefits. In 2009, I was asked to set up, and we work on multiple topics: tobacco control, automobile safety, diabetes, sexual behavior, alcohol, excessive alcohol consumption. In 2009, I was asked to organize a project, a systematic review series on health equity, which, as I said, we define as equity not only in health outcomes, but in social determinants. For the first 7 years, we worked on educational interventions, and our notion of education was different from the usual public health interventions. It's true that kids have to be healthy to go to school and learn, and physical activity is important for them to learn, and healthy behaviors are important to learn. Our interest was more in way downstream benefits of education. Creating kids who could solve problems, interact effectively, know how to move around in the world, and thus get good jobs, live in healthy places, pursue healthy behaviors, be creative, productive, and participating citizens. And we looked at 6 or 7 interventions. We looked at early childhood education, preschool, which has many long-term effects. We looked at full day versus half-day kindergarten. We looked at after-school, summer school programs. We looked at school health clinics, which in poor neighborhoods are very important for multiple educational as well as health outcomes. We looked at year-round calendars. We looked at which are questionably beneficial, and we looked at extended school days, years, and so on, which are also questionably beneficial. And we looked at dropout prevention, which is a very serious problem in many of the communities we're interested in. And many of those programs are beneficial. And we publish all these, and we hope that policymakers and local governments and program developers will pick these up and use them. And sometimes we hear they do. I think your predecessor in the public health department told me that she used one of our alcohol reviews to make maps of where in Baltimore where excessive alcohol consumption was taking place, and to use zoning to restrict that to improve local public health. We've also had some feedback on some of our educational interventions, although those have been fairly recent. So as of about 4 months ago, we have switched from education to housing with similar upstream focus. We're going to look at homelessness programs. We're going to look at voucher programs, move to opportunity kinds of programs, and we're going to look at the environment of housing. It's not only the quality of your house and the affordability of your house that matters, but where that house is. And segregation is a huge problem, as I noted. And so we're going to look at the environment of housing and inclusionary and exclusionary zoning and that sort of thing. I might not be around for the whole thing, but these things usually take 6 or 7 years to do. But that's the direction we're going in. We're also, my successor may look at employment and other things, transportation and other things as well. So that's the goal of this project, and we hope to contribute to equity by moving in this direction.
Thank you, Robert. Leana, I just have one more question, and I think this is an issue that's on the top of a lot of people's minds, and that this is the issue of opioid addiction. And I know that Baltimore has been grappling a lot with this opioid crisis, as well as a failed war on drugs. So, and as we know, addiction to opioids is not the only addiction issue that we struggle with. So I'm wondering how the Baltimore City Health Department's opioid overdose prevention and treatment initiatives actually address and try to remedy some of the historical racial inequalities in society's response to this problem.
Thank you. I'm glad to end with this with this question, actually, because it's something that we focus on a lot for a couple of reasons. One is that it's literally about saving lives. I mean, here in Baltimore City, we have twice as many people who died from overdose last year than died from homicide. And it's a matter of somebody is dying in front of us, we have to save their lives right now, or else there's no chance for them to have any better tomorrow, right? I mean, working in the ER, I've given naloxone or Narcan, the antidote, hundreds of times. And it seemed unconscionable to me that if we have an antidote and it's an epidemic, we have to save people's lives right now. And so about 2.5 years ago now, in October of 2015, I issued a blanket prescription, which is a standing order for every resident in our city to get naloxone. Because why not, right? I mean, epidemic, if this were Ebola and there were an antidote, of course you would get this available to every single person. And as a result of this standing order, everyday residents, so not including paramedics or the police, but everyday residents have saved the lives of over 1,600 other residents here in Baltimore City. But I'll tell you what we face every day, which is profound stigma. There's a bill that my team testified in Annapolis on just a couple of days ago that basically says if you get revived with Narcan, you have to pay back society for the Narcan. And if you're unable to pay, you are incarcerated. And I ask you, would we ever say that? Let's say somebody comes in with heart disease. Would we ever say, well, unless you're going to follow all of our recommendations for medical treatment, we're going to make you pay back the taxpayer contribution. And after that, if you can't pay, we're going to make you go to jail because that's what's going to solve your disease. That's what's going to treat your disease. I mean, there's such huge stigma. People talk about well, if we pass out naloxone or we do needle exchange, which by the way, in Baltimore, we've been doing for over 20 years, isn't that going to make people use more drugs? Would you ever say to someone who is dying from a peanut allergy, I'm not going to give you an EpiPen because it might make you eat more peanuts? It's just as ludicrous. And I use this to illustrate the profound stigma and misunderstanding there is about the disease of addiction. And I think, it's long past time that we focus on this issue. But in order for us to focus on it, we also have to acknowledge a truth that we don't often like to talk about. I was at a community meeting a couple months ago addressing what we're doing in Baltimore City, which I'm very proud of, and addressing what we need to do more of. And this gentleman stood up in the back and he said to me, why is it, tell me this, why is it that addiction is now a public health emergency? Because there have been people in our city and around the country dying the crack epidemic, from the heroin epidemic for decades. And I think it's important for us to recognize, and confront that hard truth that when it was Black and brown people in inner cities who were dying, poor people who were dying, addiction was seen as a moral failing. So if you chose to get addicted, it's your fault. So if you end up in jail or you're dead, that's something to do with you. Versus now, it's white, suburban, rural, wealthy people who are dying. You can check yourself into a medical clinic because it's a disease. I mean, I'm not saying that we shouldn't be doing more. I mean, I'm glad that there's attention to this issue. But unless we recognize that we owe an apology to generations of minorities in inner cities, to poor people, I mean, we owe an apology. And unless we address those fundamentals, and if we don't focus on these issues, and if we don't acknowledge that violence is a public health issue, that poverty is a public health issue, that racism is a public health issue, then we're not going to make progress on overdose, and we're not going to make progress as a society.
Thank you so much, Leana. So as we move into the question and answer session, I'd like the folks in Baltimore, if you can come down and we'll take a couple of questions. And I just want to say that, thank you so much for saying that. One of the things that we need to keep in mind is that it's going to take some time to build relationships and to make ourselves trustworthy to the communities that we're working with. And just to understand that just because we come up with some solution, that everyone's not going to be ready to jump on board, that really we're going to need to take time to listen and include people and be respectful of their perspective and their concerns in order to address many of these issues. So we have a question up at the top on the balcony.
Yes, hello.
And we'll take a couple of questions and then we'll have the panel respond. So
Okay. Thank you all for coming today. My name is Janine, and I'm studying social work at University of Maryland, Baltimore. And Dr. Nguyen, when you stated that we need to recognize an apology is owed to communities of color, how can we as advocates help schools and physicians to administer the ACE testing, adverse childhood experiences, to better gauge whether or not the child actually needs an IEP or 504 plan? Because if the child is just suffering from trauma, then they need some kind of counseling. And then if they are given an IEP or 504 plan and the school is trying to address the issue, they're failing. And so that further puts the child on the conveyor belt from school to prison pipeline, further perpetuating the physical implications and mental implications that people of color experience. So how can we hold people accountable from a legal vantage point? I know insurance companies might not pay for it, but what can we do to shift that narrative?
thank you.
Thank you.
So we'll take the next question.
My name is Michelle, and I represent Parks and Recreation Agencies.
So the microphone doesn't seem to be working, but the question is related to where there are opportunities for parks and recreation to become involved in.
To address issues of health, particularly with the rising rates of obesity in our community.
Okay, thank you. Is there one more in Baltimore, and then we'll have an answer. We'll have the panel to respond.
Great. I'm Debbie Goldberg with the National Fair Housing Alliance, and I also want to say thank you for all of your wonderful presentations this afternoon. So when I listen to you all talk about the social determinants of health, it sounds exactly like a conversation that's going on in the fair housing community development world, spurred by a rule that HUD put out a couple of years called the Affirmatively Furthering Fair Housing Rule, which I don't think has gotten a lot of airtime at this conference, or at least not the parts that I've been able to attend. But it's an effort at HUD to try to bring together all these different threads that relate to the impact on your life of where you live, all the things that you all have been talking about today. And it's also an effort to try to bring together people from different sectors. I'm sorry, I forget who said we need a multisectoral approach. It might have been Dr. Mujahid. And this rule also tries to do that, and to do it in the context of planning how we're going to use the resources that we have available for housing, for community development, which HUD has some authority over, but also for health, for education, for transportation, et cetera, et cetera. So I have a two-part question. First is, given that on the one hand, we need a multi-sectoral approach, and on the other hand, everybody's worried about stepping on the toes of somebody else who works in a different field, right? So how do we bring together these different conversations to be one conversation, which I think would be more powerful and have a greater impact? And are there places around the country that you can point to where people are already coming together across these different sectors to try and tackle this common problem?
Does the panel want to respond? There are a series of questions here, one related to the educational sector, one related to parks and recs, and another one related to housing and how multi-sector groups can be effective and whether there are best practices on that.
HUD was established to promote fair housing, and but it has, in my personal view, not been very successful in doing that and maintaining its own mandate. And it has actually, according to one of its own documents, been sued multiple times for this failure, as well as being brought to the Supreme Court for this failure. yesterday, affirmatively furthering fair housing was mentioned. Maybe you weren't here for that session, but it was mentioned. Also mentioned was the ruling that intentional discrimination did not have to be proved, but that the effects of discrimination could be used as evidence of discrimination, making it easier to provide evidence of discrimination. But still, the mass of instances of discrimination that go on in housing are some very small percentage are pursued. I mentioned yesterday that it's estimated that about 2 million instances of discrimination on the basis of race in the hands of realtors have been estimated to take place, and less than 1% of these cases are brought to trial or justice. So, yeah.
Okay. So, Leana, did you want to address the question that was directed to you related to the school system?
Sure. So I chair a committee that's state mandated here in Baltimore called the Child Fatality Review Committee. And we look at every case of children who died in Baltimore City. This is one of the hardest things that I do in my job for a number of reasons. First, I'm a new mother myself, and it's hard for me to look at the cases of children and imagine this is every parent's worst nightmare. But the other reason it's so difficult is whenever we look at these children, we see that previously, almost without exception, they have had so many touch points with so many different agencies. And not only the children, but also their caregivers, their parents, even their grandparents often have had so many touch points. So the question is, they've fallen through so many cracks. They've fallen through every safety net. Why is that and what we can do? So I talk about this as a segue to talk about the adverse childhood experiences question, because when we look at all these cases of these children and their parents, their ACEs scores are through the roof, and those are only the ACEs that we know about. And if we look at the general population and the children in our city, even the ones who are not dying or are not victims of abuse and neglect, their ACEs are really high too. And so I do think it's important for us to focus on trauma. I just want to make sure that we also think about the what next. Because we don't just want to be labeling our kids as, oh, you have so many traumatic experiences. The question is, how are we going to help you next? So we're working on this. We now have mental health services expanded to 120 of our schools here in the city. Physical health services are in every school of our nearly 180 schools. But how can we go beyond that? I do want to address something else that was mentioned, which was about, where if social determinants of health is everything, or if health is everything, where do we even start? So working in the ER, it's never my option to say, I can't help this patient because they're too complicated. I mean, the patient may have heart disease and cancer and diabetes. They may be the victim of a car accident. We can never say, well, I'm not going to help this person. Somebody else should do it. And so there's a quote that I want to share by Senator Cory Booker that some of you may know, which is that we cannot allow our inability to do everything to undermine our determination to do something. So we need to all start somewhere within our sphere of influence. But if social determinants of health are everything, then each of us, no matter if we work in housing or rec and parks or whatever, there's something that we can do right now to catalyze that change.
Remarkable. So thank you so much. I wanted to make sure Mahasin got a chance to weigh in on any of the questions.
Yes, I was just comment on two things. The first is that I think we're doing a better job of not just focusing on risk, but also resilience. And so there's a lot of interest from leading health funders to not just capture the kind of problems or the bad narratives or the ACEs that our young kids experience, but also the factors that make them resilient, and trying to leverage those factors more and to share more of those stories and to raise more awareness about how we have the equivalent of kids who are in a plane every day that crashes and get up and walk away. And so know that the plane, we should not expect anyone to survive that plane crash, but we have people who are doing it every day, and we want to make sure that we're sharing those stories and we're honoring that as we think about our approaches and our strategies. And then in terms of the multisectoral approaches, I think, it is difficult, and that's the reason why we have to do it, because there has to be more education around the unintended consequences of the decisions that are being made across different sectors. And without thinking about that, we can't develop effective strategies. So one example that I can think of in Southern California was in response to this idea that there are food deserts and food swamps where there's this oversaturation of unhealthy options and limited healthy options in those areas. And so for a long time, the strategy has been to bring in supermarkets or large grocery stores without any understanding of how that affects the small mom and pops or the local economy. And so in this work in Southern California, they worked to convert small corner stores into stores that had healthier options. They brought in residents, the youth, they brought in police departments to think about loitering in those areas and sort of their interaction with the residents that might gather in front of these food stores. They talked to the store owners to figure out what are their issues around their bottom line, what do they need. They converted the stores, they brought in freezers, they thought about perishable items and what to do about that. They thought about the sensitivity around increased sales and whether that this would actually increase sales in those areas. They talked to the education system to find out if there needs to be any safe spaces created in these corner stores. And so from doing all this work across sectors, they were able to come up with stores that provided healthier options. The store owners were able to increase their revenues. People felt like it was a safe space. It was used as ways to transform communities. And it was a solution that would not have been thought of if we thought it sort of just about the idea of bringing in the large superstore. So we have to talk to one another. We have to create a shared language and understanding to really establish the effective solutions.
That's a great example. I'm familiar with that one from one of my colleagues. And I know for a fact that a lot of youth from the high schools, local high schools, were involved in the strategies that they used with those corner stores. I want to make sure we get a chance for folks in Berkeley to ask their questions. So are there a couple of questions at UC Berkeley?
Yes, we have a long line here. So I'm going to continue the pattern and ask for 3 questions and turn it over to the panel. So let's start over here, then go to this mic, and then back to this mic.
I'm a documentary filmmaker. I studied biology and intended to go into medicine, and then finding myself frustrated with the systemic situation, storytelling ended up being the best way I felt that I could help. So my question for each panelist is, if there was one misconception that could be cleared up, knowing what you know about the work that's being done right now, what would that be?
Okay, let's go over here.
Hi, my name is Deepak Premkumar, and I'm a PhD candidate here at UC Berkeley studying the economics of crime and health. I just first off would like to thank the panel. My question is in reference to something Dr. Mujahid said in reference to epigenetics and understanding how racialized stressors end up accelerating age or weathering. How does this manifest different than other types of stressors, and is there any causal study that points to these issues? Thank you.
And then back over here.
Hi, my name is Garrett Hall, and I used to live in Baltimore. It's like a second home. And since we were talking about social determinants of health, Dr. Wen, can you talk about what efforts the BCHD may be doing to advocate for the conditions in Baltimore City schools like heating, which definitely disparately affect students of color?
Okay, let's go to our panel. There were a couple of questions that were directed to specific people, so if you want to handle those first.
Yeah, I think that would be great. Mahasin, would you like to address the question related to epigenetics and racial stressors?
Yeah, so I would say that this is first and foremost sort of a new emergent. I think for a long time there has been this false dichotomy that health is either genetics and biology or it's social determinants. And there's been very little work to integrate the two, sort of really to think about a way to integrate social and genetic and biological factors to better understand health. And so the work that's going on now is really trying to understand first and foremost that there is not a biological determinism or predeterminism established by genetics, that things things are regulated throughout the life course. And so we have opportunities to modify genetic profiles. And part of this opportunity is to understand that the way in which genes are regulated through processes of DNA methylation are a function of environments. And so things like exposure to chronic stressors are actually regulating genes off and on. And so there was a question about sort of whether or not racial stressors have actually been examined. And so that work has to sort of come now that we've sort of created an opportunity to be able to do this. So the work to date has mostly focused on more race-neutral types of stressors in relation to financial strain, in relation to kind of other kinds of daily life stressors. And so then the next iteration of that work has to think about stressors that are unique to sort of experiences of racism and discrimination in this country. So I'll stop there.
Mm-hmm. Yeah, I'll just add, I think there is some work going on by some researchers at Harvard. I know David Williams is working on this, looking at sort of biological manifestations of epigenetic changes. So in response to experiences of discrimination. So that's one area, one institution that I know where there's work going on, but I know that there are lots of places around the country trying to make those connections. So Leana, there was a question specifically targeted to you about the Baltimore City school systems.
Sure. We work very closely with our city schools. And, there was a grant actually that we just partnered with our city schools on, in addition to the vision work and others that we mentioned. There was a grant that we received to partner around trauma. And there's a concept that several of my team members, several of the people who work at the health department say that I've been repeating, which is that it's hurt people who hurt people. The understanding of trauma is incomplete without thinking about the cycle and how can we then intervene to break that cycle. And I want to take this chance to acknowledge Ben Siegel, who was working closely with us at the time as the head of the Obama administration's the White House Task Force on Baltimore, I think, or some iteration of that name. But Ben was instrumental in helping us to receive grants like this as a way to address the immediate issues that we're facing in our schools, whether they're physical health issues, mental health issues, but also deeper issues. And I also want to comment on, there was a question asked about what is the number one misconception that I hope that you will all help us to clear up. I don't know, it's hard to boil it down to one, but I want to quote someone that I respect greatly, Representative Elijah Cummings, who was one of our representatives here in Baltimore, who talks about how the cost of doing nothing isn't nothing. It's something. I mean, I looked at what was happening during the Zika times. I mean, I was pregnant at the time, so and the head of public health, so I was thinking about this. But one child born with the effects of Zika will cost society $10 million. Health, economic, lost opportunities, educational opportunities. I mean, you think about that is the cost of doing nothing. Then we talked about how there's the cost of investing in mosquito control, something as basic as that. Or look at all the efforts to dismantle the Affordable Care Act, gutting Medicaid, right? I mean, one in two pregnant women here in Baltimore City depend on Medicaid. We can talk about the cost of Medicaid, but what happens so we also know that the women who do not get prenatal care are 5 times more likely to have a child who dies than a woman who does get prenatal care. Never mind the cost of having a child in the NICU, which could cost millions of dollars. So that, I think, encapsulates public health, not just the cost of an intervention, but let's also ask about the cost of doing nothing.
Right. I think that's great. That's great. Yeah. I think I would also try to dispel the myth that if we invest in one person, then that means we're taking away from someone else. And I think I would also try to help people see how connected we are to one another in this global environment. Actually, the fact that what people are experiencing over here may be today what that group is experiencing, but the reality of it is that it impacts us all. And so watching people be exposed to violence on television has a negative effect on all of us, whether we're living in that same neighborhood or whether we're living someplace else. I think there are a couple more questions in Berkeley.
Can may I?
And so Robert wants to weigh in on.
I wanted to respond to that.
Excuse,
If I could choose one misconception related to this issue that I would like to change, it would be public conception about the biology and race. I think most of us here probably recognize that race is a notion that was largely invented by white Europeans in order to justify their exploitation of the rest of the world. But the most important thing is that most racial differences in biology are the consequences of racism and not race. And Ta-Nehisi Coates has said this, and I just wish that we could convince the public of this and change and make them see the power of racism that persists in our society and that is the root of this report that we're celebrating and of continuing disparities in social determinants and in health.
Thank you. And we're actually out of time. So I'd like to thank all the panelists.